It's not air filling the chest this time, it's blood, and the lung is drowning from the outside in. Welcome to this explainer on hemothorax. We're going to break down exactly what you need to know to conquer this Med-Surg topic for the NCLEX. If you want to understand the why behind it, so you don't have to just blindly memorize things, well, you're in the right place. Let's dive right in.
So picture this. A patient rolls into the ED right after some severe blunt force trauma to the chest. They're gasping for air, their blood pressure is absolutely tanking, and it's a total race against the clock. This right here, this is a hemothorax. The crucial thing to understand is that a hemothorax actually creates this massive two-front war in the body. Threat number one is lung compression. Blood is taking up the exact space that the lung desperately needs to expand, which leads straight to respiratory failure. But at the exact same time, you're battling threat number two, which is blood loss. All that blood filling up the chest cavity, yeah, it's leaving the circulatory system, plunging your patient straight into hypovolemic or hemorrhagic shock. So you basically have to fix the lung and refill the tank at the exact same time.
Section 1. The hidden hemorrhage. Pathophysiology.
Let's step through the hidden physiological breakdown that happens the second trauma strikes the chest wall. And look, understanding this makes all your nursing interventions just click into place. So it starts with step 1, vessel injury. Whether it's blunt trauma, a penetrating wound, or a fractured rib, something lacerates the chest wall, the lung, or the great vessels. Then, step 2, blood rapidly fills the pleural space. And what's wild here is that the chest cavity basically acts like this massive hidden reservoir. I mean, it can hold liters of blood before you ever see a single drop on the outside. Step 3, as that blood pools down in the dependent or lower pleural space, it literally squeezes the lung upward, compressing it and causing severe dyspnea and hypoxia. Step 4, because all that blood is no longer circulating in the vasculature, while circulation drops, the patient's heart rate spikes into tachycardia, and their blood pressure just plummets into hypotension. Which brings us to step 5, without immediate intervention, this massive hemothorax leads directly to shock and cardiac arrest.
Section 2. Signs, symptoms, and labs.
Okay, so what does this actually look like when you walk into the patient's room? What are those red flags the NCLEX is definitely going to throw at you? You're basically looking at respiratory distress combined with classic signs of hemorrhage and shock. Your patient is going to have dyspnea and tachypnea as they fight to breathe against that compressed lung. And when you listen in, you'll hear decreased or even completely absent breath sounds on the affected side. Plus, you'll see the shock setting in, right? Tachycardia, hypotension, and that classic pallor with cool, clammy skin.
Now watch out, because here is a massive NCLEX trap. You absolutely must know the difference between a hemothorax and a pneumothorax when you percuss the chest. If you percuss over a hemothorax, you are going to hear dullness. Why? Because you're tapping over a dense pool of fluid and blood. But if it were a pneumothorax, you'd hear hyperresonance because you'd be tapping over trapped air. Just remember, fluid or blood sounds dull, air sounds hyperresonant.
Moving on to key labs and diagnostics. You'll be watching hemoglobin and hematocrit, obviously. But here is a big pro tip. That H&H, it might actually look totally normal at first before it suddenly drops, so you really have to trend it. You also immediately need to type in cross-match to prep for blood transfusions. On a chest x-ray, you're going to see a blunted costophrenic angle or even a complete whiteout if the bleeding is massive enough. And finally, you'll be relying on the ultimate diagnostic and treatment tool combined, monitoring the chest tube output volume.
Section 3. Priority nursing interventions.
All right, the diagnosis is confirmed. Let's talk about your nursing priorities. We're going to structure these strictly by your ABCs so we can treat both the respiratory and circulatory threats. Number 1, airway and breathing. Sit that patient right up in high Fowler's position if they can tolerate it and get that oxygen going to relieve the hypoxia. Number 2, circulation. You need 2 large-bore IVs established pronto so you can rapidly push fluids and blood products to fight off that hemorrhagic shock. Number 3, the provider is going to insert a large-bore chest tube to drain out all that blood and help the lung re-expand. Number 4, you've got to watch that chest tube output like a hawk. And number 5, pain control. Because think about it, if they're in sheer agony from a chest tube or a broken rib, they aren't going to take deep breaths, and that just leads to even more respiratory failure.
Section 4, massive hemothorax emergencies. Now, we need to talk about the danger zone. You have to memorize the exact chest tube drainage numbers that signal a life-threatening surgical emergency, because the NCLEX loves testing this. If that chest tube goes in and you see an immediate, massive gush of more than 1,500 milliliters of blood right off the bat, yeah, you are dealing with a massive hemothorax. Or if you're monitoring the patient and that chest tube is dumping more than 200 milliliters per hour for 2 to 4 hours straight, listen to me very carefully here, that is not good drainage. Sometimes you think, oh great, the blood's coming out, the tube is working. No way. A volume like that means there is an active, ongoing arterial bleed inside the chest. If you see either of those numbers, greater than 1,500 milliliters initially or greater than 200 milliliters per hour, you notify the provider instantly. Period. This patient has failed conservative management, and they need to be rushed straight to the OR for an emergency thoracotomy to stop the bleeding. Section 5. NCLEX Test Yourself. Okay, let's lock all this in with some active recall using real-world NCLEX-style questions. Get ready to drop your answers in the comments. Question 1. A client with a chest tube for a hemothorax has drainage of 250 milliliters per hour of bright red blood for 3 hours. What is the nurse's priority action? Is it A, document the expected finding, B, notify the provider immediately, C, clamp the chest tube, or D, milk the tubing vigorously? Take 3 seconds and lock in your answer. 3, 2, 1. The correct answer is B, notify the provider immediately. Let's look at the rationale. Sustained drainage over 200 milliliters per hour indicates ongoing hemorrhage that requires surgical intervention. It's a huge red flag. A is wrong because, well, this is a deadly emergency, not an expected finding. C is just downright dangerous. Clamping the tube causes the blood to back up, recompress the lung, and could cause a tension hemothorax. And D is outdated practice that can actually damage lung tissue.
Let's try question 2. Which percussion finding is expected over a hemothorax? A, hyperresonance, B, dullness, C, tympany, or D, no change. Lock it in. 3, 2, 1.
And the answer is B, dullness. As we covered earlier, blood pooling in the pleural space acts as a dense fluid barrier, and fluid produces a dull sound when you percuss it. If the question had asked about a pneumothorax instead, the answer would have been A, hyperresonance, because you'd be percussing over trapped air.
So, what's the ultimate takeaway here? Here is your final memory hook to sear into your brain before you sit for that exam. Master hemothorax. Blood equals dull plus shock. Just remember that it's blood causing that dull percussion sound, and that blood loss is driving the hemorrhagic shock. If you keep that straight, you'll absolutely nail any question they throw at you on this topic. Before you go, think about this. If your patient with a hemothorax suddenly develops tracheal deviation, what secondary deadly complication just occurred? Think on it. If this made it click, subscribe. One killer Med-Surg topic every day until you pass the NCLEX. Keep studying hard, stay focused, and I'll see you in tomorrow's Explainer.